So it's very good to have two targeted agents. Well, we have more actually now, but two targeted agents, Brentuximab and Pembrolizumab. And one of the sort of debates that we're having now is what sequence do you use? When do you use Pembrolizumab or nivolumab, the two PD-1 inhibitors? When do you use Brentuximab? We have the Keynote 204 trial, which actually compared the two. And what that showed is that the duration of remission and the progression-free survival rates were longer with the PD-1 inhibitor, Pembrolizumab. Does that mean we should always use it before Brentuximab? Well, I mean, not necessarily. Let me give you an example. You've got a young patient, let's say 28, who's primary refractory to ABVD, and they've had first-line relapse chemo, GDP, and had a sort of not very good partial remission. You want to get them into a better remission before an autograft. Which one do you go for? Well, you could use Pembrolizumab, but the complete response rate with Pembrolizumab is about the same as Brentuximab, maybe a little bit less, and you really want a complete response, if possible, to take them to an autograft. And also to do an autograft is just chemotherapy. So ideally, you would want to prove your patient is chemo responsive. Now, Pembrolizumab isn't chemo, it's an immunotherapy. So you might go with Brentuximab first, see if they're chemo responsive, try and get that CR. And if that doesn't work, go for a PD-1. However, you might flip the argument and say, but there's chemosensitization associated with PD-1 inhibitors probably. So let's use PD-1 before an autograft so that they're more sensitive for the following autograft. Which one is right? I don't know. There's going to be an ongoing debate, and we do need more data really of the outcomes of autologous stem cell transplant following PD-1 inhibitors. And of course, there may be patient-specific factors which really tell you which way to go. If somebody's got a history of Crohn's disease, then I probably wouldn't be giving them a PD-1 inhibitor because it may reactivate or cause a flare of that autoimmune condition. Likewise, if somebody has, grade 2 peripheral neuropathy from their first-line treatment, or indeed had AVD Brentuximab as their first-line treatment, I probably wouldn't be retreating them in that situation with Brentuximab. I think that the situation where it's perhaps a little bit clearer are the older patients who are on their second relapse, so third-line treatment. I probably would use Pembrolizumab first there because, you normally go for the treatment that gives the longer progression-free survival when you're not in a sort of curative approach.